Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 283 of our Pharmacotherapy MCQ series, which majors in peripheral vascular disorders. The first question reads, P.R.L. is a 60-year-old, 110-kilogram man with a history of type 2 diabetes mellitus, chronic stable angina, dyslipidemia, and smoking. His chief complaint today is right upper thigh pain while walking around the block. The pain has gradually increased during the past 12 months, but only recently has become intolerable. The pain is relieved within minutes after he stops walking. P.R.L. smokes 2 packs of cigarettes a day. His most recent laboratory results are significant for the following results. Total cholesterol of 290 mg per deciliter. The SI units are 7.49 millimoles per liter. Fasting triglycerides, 350 mg per deciliter. The SI units are 3.95 millimoles per liter. Low-density lipoproteins (LDL), 188 mg per deciliter. The SI units are 4.86 millimoles per liter. High-density lipoproteins (HDL), 32 mg per deciliter. The SI units are 0.83 millimoles per liter. Serum creatinine of 0.8 mg per deciliter. The SI units are 61 millimoles per liter. Blood urea nitrogen of 18 mg per deciliter. The units are 6.4 millimoles per liter. Hemoglobin A1C of 10.5%. The SI units are 91.3 millimoles per mole. Fasting glucose, 190 mg per deciliter. The SI units are 10.5 millimoles per liter. Blood pressure, BP, 170 systolic, 95 diastolic. Heart rate of 89 beats per minute. His posterior tibial artery pulse is not palpable. A Doppler ultrasound study is performed, and his ankle-to-brachial index, abbreviated as ABI, is 0.7. The normal value should be above 0.9. P.R.L.'s medication list includes isosorbide mononitrate 60 mg daily, aspirin 81 mg daily, and ramipril 5 mg daily. His insulin doses have progressively increased to neutral protamine hagedorn, abbreviated as NPH, insulin 40 units in the morning and 35 units in the evening. So my question to you is, what risk factors and elements of P.R.L.'s presentation are consistent with a diagnosis of intermittent claudication, abbreviated as IC? P.R.L.'s medical history illustrates classic risk factors for vascular occlusion and intermittent claudication, abbreviated as IC, including dyslipidemia, diabetes, hypertension, and smoking. His diabetes is not adequately controlled based on elevated hemoglobin A1C and fasting glucose levels, and he is obese. This constellation of disorders is known as the metabolic syndrome. These factors, along with smoking, are commonly seen together and have been linked with insulin resistance and accelerated atherosclerosis. The presence of angina indicates coronary artery disease, so it is not surprising that he has peripheral vascular occlusion as well. The classic pain of intermittent claudication described by P.R.L. is associated with exercise of the affected muscle group or groups, and subsides with a few minutes of rest. Other common symptoms of extensive atherosclerosis include cold feet and persistent aching of the feet during rest or sleep. Restricted blood flow to the feet along with pooling of blood secondary to inadequate pressure needed to propel blood back up the leg can lead to rubor, red or purple color of the foot. Other indicators of peripheral atherosclerosis are the loss of hair from the top of the feet, thickening of the toenails, and absence of sweating of the lower legs and feet, all caused by poor circulation. The results of objective studies performed on P.R.L. are consistent with intermittent claudication. Doppler ultrasound of the spine is helpful in excluding pseudoclaudication caused by spinal stenosis and other neurogenic or musculoskeletal causes of leg pain. Ultrasound is also useful to measure BP of the lower extremities. An ankle to brachial index of 0.7 means that the ankle systolic BP reading is only 70% of the systolic pressure in the brachial artery supplying blood to the arm. In patients with intermittent claudication, this is caused by atherosclerotic obstruction of blood flow in the lower limbs and subsequent decreased perfusion pressures in the ankle compared with the arm. As the ankle to brachial index decreases, blood flow to the extremities is reduced and the severity of symptoms is greater. An ankle to brachial index less than 0.9 is diagnostic for PAD. Loss of the posterior tibial pulse, as seen in P.R.L., is common in those with peripheral vascular occlusion. The next question reads, what are the therapeutic goals in treating P.R.L.? What interventions should be initiated to prevent claudication pain and arrest progression of his disease? Specific treatment goals include preventing further claudication pain, lessening his current pain, arresting the progression of underlying disease, and decreasing his risk of cardiovascular events. Achieving these goals will provide P.R.L. with the best chance of avoiding further mobility impairment, amputation, and cardiovascular events. An important concept that should be stressed when explaining these treatment goals to P.R.L. is that all his diseases are closely interrelated and that a beneficial intervention for one disease is beneficial for all. Interventions that can be initiated include diet modification, exercise and weight loss, and attainment of goal BP, lipids, hemoglobin A1c, and fasting and postprandial blood glucose levels. The American College of Cardiology and American Heart Association (ACCAHA) have published guidelines that thoroughly evaluate the interventions and medications that have been used to treat intermittent claudication and PAD. The two most important things that P.R.L. can do for his intermittent claudication are summed up in 5 words. Stop smoking and keep walking. We will begin with smoking cessation. The importance of smoking cessation cannot be overemphasized to patients with intermittent claudication. It is the most important modifiable factor in preventing the development of rest pain, prolonged limb ischemia, need for amputation and reducing the risk for cardiovascular events. Several studies document improved survival and decreased amputation rates in patients with intermittent claudication who stopped smoking compared with patients who continue to smoke. Other benefits, such as improved treadmill walking distance, decreased disease progression, and decreased complications after vascular reconstructive surgery, have been shown in patients who quit smoking compared with patients who continue. It is the one intervention that will decrease P.R.L.'s claudication pain most rapidly. He will also decrease his risk of MI and mortality by 3-fold and 5-fold, respectively. Many pharmacologic products and strategies are available to aid P.R.L. to stop smoking. However, nicotine itself has harmful effects on the vasculature via catecholamine release and vasoconstriction, and it may play a role in endothelial damage and atherosclerosis progression. We will now look at exercise. An individualized and supervised exercise program is endorsed for patients with PAD and will benefit most of P.R.L's other risk factors as well. Intermittent claudication pain results in decreased mobility, and because of deconditioning from lack of exercise, patients with intermittent claudication may slowly become dependent on others for activities of daily living. An exercise program is the most effective way to both preserve and increase mobility. It is more effective than the best pharmacologic therapy currently available. The ideal exercise program consists of walking for a minimum of 30 to 45 minutes at least 3 times a week, for a minimum of 12 weeks. P.R.L. should walk as fast and far as he can until the pain becomes severe. He should then wait until the pain subsides, and then resume walking. At first, P.R.L. may experience several painful episodes during each exercise session, but these should gradually decrease as the beneficial effects of exercise therapy begin to emerge. Studies have documented that this type of exercise program can more than double the pain-free distance a patient with intermittent claudication is able to walk. Lower extremity resistance training can provide improved functional performance measured by the following: quality of life, treadmill walking time, and ability to climb stairs. An appropriate exercise program results in superior outcomes compared with angioplasty and stenting, and equal in terms of walking distance compared with surgery, but without any of the significant complications and mortality associated with surgery. Rheologic abnormalities of increased blood viscosity, impaired RBC filterability, hyperaggregation, and polycythemia, elevated hematocrit, have been shown to return to normal in many patients with intermittent claudication who participate in a regular exercise program. Exercise may offset the need for pharmacologic intervention. The next question reads: is lipid-lowering therapy indicated for P.R.L.? Because intermittent claudication is a consequence of atherosclerosis, arresting the progression of P.R.L's atherosclerotic disease is important. Initiation of the nutritional and exercise recommendations should be recommended as outlined in 2013 ACC/AHA Lifestyle Management to Reduce Cardiovascular Risk Guidelines and endorsed by the ACC/AHA Guideline on the Treatment of Blood Cholesterol to Reduce Atherosclerotic Cardiovascular Risk in Adults. Therapeutic lifestyle changes and cholesterol-lowering agents are the cornerstones for attaining this goal. Considerable data suggest that aggressive dietary and pharmacologic management of dyslipidemia, particularly lowering low-density lipoprotein cholesterol (LDL cholesterol), leads to regression of atherosclerotic lesions in the coronary and carotid vasculature. In contrast, relatively few prospective data exist about the effect of successful lipid-lowering therapy on the regression or stabilization of peripheral lesions, or on clinical events in patients with PAD. A post-hoc analysis of a large lipid-lowering study in subjects with known coronary artery disease treated with simvastatin demonstrated a significant decrease in new or worsening intermittent claudication, suggesting that in high-risk patients, lipid lowering can prevent development of clinically symptomatic PAD. The Heart Protection Study randomly assigned patients with known arterial disease of various types to simvastatin 40 mg daily or placebo. After 5 years, a 15% decrease was found in non-cardiac revascularizations, including amputations, among the patients receiving simvastatin. 40 short-term outcomes, e.g., 6 months to 1 year, such as improved walking distance and walking time, have also been documented with simvastatin 40 mg per day. A meta-analysis of 10,049 subjects from several randomized trials using a variety of lipid-lowering therapies in patients with PAD demonstrated reduced claudication severity and decreased disease progression as measured by angiography. A decrease in mortality did not reach statistical significance. Limited data suggest high apolipoprotein, abbreviated as Lp(a) concentrations may be particularly important in the development of PAD. Patients with PAD fall into one of the 4 major statin benefit groups, specifically falling into the group with known atherosclerotic cardiovascular disease, abbreviated as ASCVD. Since P.R.L. is less than 75 years old, he warrants high-intensity statin therapy, which is defined as statin therapy at doses that are expected to provide at least a 50% reduction in LDL cholesterol. There is a paucity of outcome data with other agents for dyslipidemia, as recent trials of omega-3 fatty acid, niacin, or fibric acid derivative have failed to demonstrate a reduction in cardiovascular events in patients with increased risk for cardiovascular events like P.R.L. The next question reads, P.R.L.'s BP is elevated to 170 systolic, 95 diastolic despite ramipril therapy. Because he has angina, and his heart rate is 89, a beta-adrenergic blocker is considered. So my question to you is, are there alternative antihypertensive therapies that might be preferable for P.R.L.? P.R.L.'s hypertension has likely contributed to the development of his atherosclerosis, and PAD hypertension has been associated with deficiencies in the synthesis of vasodilating substances, such as prostacyclin, bradykinin, and nitric oxide, by the endothelial cells lining the vasculature, along with increases in vasoconstricting substances like angiotensin II. Increased vascular tone can alter local hemodynamics, especially in the presence of a stenotic lesion. Although it has not been determined whether normalization of BP has a positive effect on intermittent claudication, it is well established that uncontrolled BP results in vascular complications such as MI and stroke. In light of P.R.L.'s numerous risk factors for these complications, improvement in his BP is warranted. Beta blockers are frequently cited as contraindicated in intermittent claudication patients owing to the potential for unopposed alpha-adrenergic-mediated vasoconstriction during peripheral beta blockade. However, evidence to document worsening intermittent claudication by beta blockade is lacking. Overall, controlled studies have been inconclusive, and a meta-analysis of placebo-controlled trials and studies with control groups concludes that beta blockers do not worsen claudication. Angiotensin-converting enzyme inhibitors are first-line agents in patients with PAD. Compared with other antihypertensive agents, the data available support their beneficial effects in this population. Compared with placebo, walking distance is increased with both perindopril and ramipril in patients with PAD. The Heart Outcomes Prevention Evaluation, abbreviated as HOPE study, compared ramipril versus placebo in over 9,000 patients who had evidence of vascular disease or diabetes. Impressively, they enrolled more than 4,000 patients with PAD, and similar to the overall trial population, patients with PAD derived a benefit in the composite endpoint of decreased mortality, MI, and stroke. The on-target trial compared telmisartan, ramipril, and the combination of the two in patients with vascular disease or high-risk diabetes without heart failure for a composite endpoint of cardiovascular death, MI, stroke, or hospitalization for heart failure. The results suggested equivalency of telmisartan to ramipril for the primary endpoint with similar BP reduction in both groups. However, the combination therapy group experienced more adverse events without any benefit. Based on these data, angiotensin II receptor blockers may be a suitable substitute for ACE inhibitors, but combination therapy is not recommended. P.R.Ls. BP goal is less than 140 systolic 90 diastolic. His dose of ramipril could be increased, or a low-dose diuretic, such as hydrochlorothiazide or chlorthalidone could be added. Given his history of chronic stable angina, the addition of a calcium channel blocker or a beta blocker would be an option as well. The accomplished trial compared the combination of benazepril amlodipine with benazepril hydrochlorothiazide in patients with hypertension who were at high risk for cardiovascular events. Amlodipine therapy reduced cardiovascular events compared with hydrochlorothiazide, even though BP control was not significantly different. While beta blockers are typically used in patients with coronary artery disease, the outcome data supporting their use are less clear. The next question reads, will improving P.R.L's diabetes control or slow the progression of his PAD? What changes in his diabetes management do you recommend? Patients with type 2 diabetes mellitus are able to minimize macrovascular and microvascular complications of the disease with aggressive glucose control. Insulin, sulfonylurea, or metformin therapies have a beneficial effect on slowing the development of the microvascular complications of diabetes, such as retinopathy and nephropathy. Metformin has specifically been shown to further reduce the occurrence of macrovascular complications such as stroke or MI compared with insulin or sulfonylureas in obese patients with type 2 diabetes mellitus. P.R.L's diabetes is a significant risk factor for progression to further ischemic events. He has a twofold greater risk of death and a sevenfold greater risk of amputation compared with a patient without diabetes. Although a specific benefit for intermittent claudication has not been demonstrated, it seems prudent to initiate or continue aggressive diabetes management in patients with type 2 diabetes mellitus and intermittent claudication. The addition of metformin to P.R.L's therapy could improve his blood glucose control and decrease his risk of vascular complications. It is hoped that P.R.L can reach his hemoglobin A1c goal of less than 7% and a fasting blood glucose of 80 to 130 mg per deciliter and 2-hour postprandial glucose of less than 180 mg per deciliter with diet and exercise, while adding metformin to his current therapy. P.R.L also must take proper care of his feet to prevent ulcerative complications of IC. He should be encouraged to keep his feet warm, dry, and moistured and to wear properly fitted shoes and perform daily foot inspections. He should seek medical attention immediately for minor trauma to his feet or legs. These measures can reduce the incidence of amputation in patients with diabetes. The next question reads, is P.R.L's aspirin therapy beneficial for preventing further complications of intermittent claudication? Would alternative antiplatelet therapies offer advantages over aspirin? Aspirin is one of several antiplatelet agents that may be considered for indefinite use in patients with PAD. There is limited data on the effects of aspirin on intermittent claudication symptoms. Whether aspirin has any beneficial effects on walking distance or claudication pain has not been studied. Available data address the impact of aspirin on overall cardiovascular morbidity and mortality. Although aspirin has no direct effect on plaque regression, it does prevent and retard the role platelets play in the thrombogenic events that occur in the vicinity of atherosclerotic plaques. Aspirin is an effective antithrombotic agent at dosages ranging from 50 to 1,500 mg daily. The lowest dosages proven to decrease cardiovascular events are 75 to 100 mg daily, with the higher dosage showing benefit in active processes, such as acute ischemic stroke and acute MI. A dosage of 75 mg daily has demonstrated benefit in patients with hypertension and stable angina. No evidence indicates that these low doses are any more or any less effective than dosages of 900 to 1,500 mg daily. Aspirin is recommended in patients with vascular disease of any origin. This includes stroke, MI, PAD, and ischemic heart disease. At dosages of 75 to 162 mg per day, aspirin decreases vascular death by approximately 15% and all serious vascular events, such as MI, stroke, or vascular death, by approximately 20% in high-risk patients, including those with PAD. In patients with PAD, aspirin can delay the progression of established lesions as assessed by angiography. When used for primary prevention of cardiovascular disease in men, aspirin decreased the need for arterial reconstructive surgery, which was needed because of PAD. In a meta-analysis of 5,269 subjects with PAD, aspirin was associated with a significant reduction in non-fatal stroke with a statistically insignificant decrease of cardiovascular events. However, in a recent large randomized controlled trial in 3,350 patients 50 to 75 years of age without clinically evident cardiovascular disease but with a screening ankle to brachial index of 0.95 or less, aspirin 100 mg per day was found to be no more effective than placebo in reducing the primary endpoint of fatal and non-fatal coronary events, stroke, or revascularization, 13.7 events per 1,000 person-years in the aspirin group versus 13.3 in the placebo group, hazard ratio, 1.03, 95% confidence interval, 0.84 to 1.27. Because all dosages of aspirin are similarly efficacious in decreasing vascular events in this patient population, side effects influence the dose chosen. Although few studies have directly compared varying doses, side effects appear to be dose-related. Aspirin 30 mg daily results in less minor bleeding compared with approximately 300 mg daily, and 300 mg daily results in fewer gastrointestinal (GI) side effects compared with 1,200 mg daily. Therefore, P.R.L. should take the lowest effective dose of aspirin, 75 mg to 100 mg daily. Of note, P.R.L.'s hypertension should be controlled before initiating aspirin therapy to decrease the small increased incidence of cerebral hemorrhage associated with its use. Ticlopidine is a thienopyridine derivative that blocks adenosine 5-diphosphate (ADP) receptors on platelets and decreases platelet fibrinogen binding. Several studies document its efficacy in patients with PAD on endpoints such as walking distance, cardiovascular death, and the need for revascularization surgery. However, hematologic toxicities, neutropenia and, rarely, thrombotic thrombocytopenic purpura limit its use. Clopidogrel initially replaced ticlopidine largely because of its improved safety profile. The effects of clopidogrel on specific PAD outcomes are unknown, but it has been compared with aspirin in patients with known atherosclerotic disease. Dosages of 75 mg daily significantly reduced cardiovascular endpoints by approximately 25% compared with aspirin in this patient population. The treatment effect was most pronounced in the PAD subgroup, leading to the suggestion that clopidogrel may be preferable in the patient population with PAD. No measure was taken of clopidogrel's effect on walking distance or claudication pain, however, and these results have not been confirmed by further studies. The combination of aspirin and clopidogrel was compared with aspirin alone in more than 15,000 patients at high risk of vascular events, of whom greater than 20% had a history of PAD and approximately 10% had intermittent claudication. In this large study that assessed cardiovascular endpoints, no benefit was found for dual antiplatelet therapy with aspirin plus clopidogrel. Thus, while clopidogrel has the same guideline recommendation as aspirin clinically, it is often used as an appropriate alternative to aspirin in patients unable to take aspirin therapy, perhaps owing to a serious allergy. It should not be used in addition to aspirin, however, because the risk of bleeding and increased cost outweigh any measurable vascular benefit. Ticagrelor was compared with clopidogrel in 13,885 patients with known symptomatic PAD but without documented coronary artery disease. There was no difference between the two groups with regards to the primary composite endpoint of death, myocardial infarction and stroke. Based on these data, ticagrelor cannot be recommended to reduce the risk of cardiovascular events in PAD patients at this time. These data also question whether there are differences in cardiovascular risk in patients with both coronary artery disease and PAD versus those with PAD alone. The next question reads, are there any medications that can be used to increase the walking abilities of patients with intermittent claudication? Cilostazol is one of the few agents approved by the U.S. Food and Drug Administration (FDA) specifically for the treatment of intermittent claudication. Several studies have confirmed that cilostazol 100 mg twice daily increases walking distance by approximately 50% and that discontinuation of cilostazol results in a decline in function. Cilostazol possesses antiplatelet and vasodilatory effects mediated by the inhibition of phosphodiesterase 3. In vitro observations suggest that these pharmacologic effects of cilostazol are particularly pronounced at the blood vessel interface, which may explain its particular efficacy in the patients with PAD. Studies that included quality of life measurements have found that cilostazol improved overall quality of life. Small improvements in ankle to brachial index with chronic cilostazol therapy have also been observed. Two small studies indicate cilostazol is associated with a reduction in restenosis after endovascular therapy in femoropopliteal lesions. Despite these positive findings with cilostazol, several drawbacks exist. It is contraindicated in patients with heart failure based on data with other phosphodiesterase inhibitors demonstrating excess mortality, presumably due to increased arrhythmias. Other common side effects include headache, occurring in up to 1/3 of patients, and loose stools or diarrhea. Cilostazol is a cytochrome P453A4 substrate, therefore, any inhibitor of this enzyme system may substantially increase cilostazol concentrations. Cilostazol is an important advancement in the treatment of intermittent claudication. It is the first pharmacologic agent to demonstrate a consistent effect on a significant source of intermittent claudication disability, walking and mobility measures. While limited data address its impact on other important endpoints, such as amputation and revascularization procedures or cardiovascular events, it should be added to P.R.L's existing medication regimen at a dosage of 100 mg twice daily to attenuate his symptoms of intermittent claudication. The next question reads, has pentoxifylline been shown to be efficacious in patients such as P.R.L? How does this drug benefit patients with intermittent claudication? Pentoxifylline, a methylxanthine derivative, is another agent approved by the FDA for the treatment of intermittent claudication. Pentoxifylline appears to decrease blood viscosity by decreasing fibrinogen, improving the deformability of both red and white blood cells, and eliciting antiplatelet effects, although the exact mechanism of action is unclear. While the theoretic and in vitro data are unique and positive, data demonstrating its clinical usefulness are controversial. Improvements in walking distances from study to study are unpredictable, and the clinical importance of the sometimes minimal increases in walking distances is not clear, e.g., pain-free walking of approximately 30 meters greater than with placebo. Some experts assert that these potential benefits of questionable clinical significance are not worth the expense of drug therapy or the GI side effects. Pentoxifyline's role in intermittent claudication therapy is limited. It may have a role in patients who are unable to engage in exercise therapy, or in patients with markedly reduced walking distances, or in whom any small increase in walking distance would greatly improve a patient's activity level. It also may be tried in patients who have not gained the desired benefit from smoking cessation and exercise therapy, and in patients with contraindications, intolerance, or failure of C-lostazole. A 2-month trial of pentoxifylline is adequate to determine whether the patient will benefit from therapy. P.R.L is not severely debilitated, and the benefits of smoking cessation, exercise therapy, and C-lostazole have not been fully realized. Therefore, pentoxifylline should not be added until his response to these well-proven therapies has been determined and the need for further improvement in walking distance is established. The next question reads, P.R.L is already taking isosorbide mononitrate for angina. Because intermittent claudication is made worse by vasoconstriction, should another vasodilating agent be added to treat both his hypertension and intermittent claudication? The use of vasodilators for P.R.L would at first appear to be a logical pharmacologic intervention to prevent claudication pain. Vasodilators, including isosorbide, directly or indirectly relax blood vessel walls and increase both skin and muscle blood flow as long as cardiac output is maintained. With obstructive arterial disease, however, vessels are sclerotic and unable to further dilate. As a result, healthy vessels dilate to a greater extent than diseased vessels, and blood flow is redistributed, shunted, away from areas that have the greatest need. BP and perfusion paradoxically drop even further in tissues affected by atherosclerosis, resulting in increased pain. If this process produces ischemia, it is known as the Steele phenomenon. Thus, while nitrates are not contraindicated in patients like P.R.L, they may not be as helpful as their mechanism of action may suggest. Numerous vasodilators, i.e., prostaglandin E1, prostacyclin, isoxaprine, papaverine, efavirenz, cyclandylate, niacin derivatives, risipine, guanethidine, methyldopa, tolazoline, nifedipine, have been used to treat intermittent claudication. None, however, has convincingly or consistently improved exercise performance, despite earlier beliefs that they were effective. Limited data suggest L-carnitine 1 gram twice daily may have benefit in walking distance and initial claudication distance. ACE inhibitors are the exception to this rule, as their beneficial effects are likely independent of their vasodilator properties. One small, controlled study demonstrated improvement in walking distance with verapamil, a calcium channel blocker, compared with placebo in patients with intermittent claudication. Further studies with verapamil are needed before its use can be recommended. Smoking cessation, an exercise program, and cholesterol are the interventions that should reduce P.R.L's symptoms of IC to the greatest degree. Verapamil is a moderate cytochrome P453A4 inhibitor and would be expected to increase concentrations of C-lostazole. The magnitude of this interaction has not been characterized, nor has its impact on efficacy and bleeding events been assessed. Based on the necessity of C-lostazole therapy in P.R.L., along with the poorly characterized benefits of verapamil in intermittent claudication and the plethora of other antihypertensive and antianginal agents, avoidance of verapamil is prudent at this time. If additional BP or antianginal effects are needed, beta blockade or amlodipine can be initiated. The next question reads, if P.R.L. was deemed as being high risk for a cardiovascular event while on aspirin, what other antithrombotic therapy options could be initiated? While there is limited data regarding antithrombotic therapy in patients with PAD, recently one new agent has been approved with potential to provide a benefit in reducing cardiovascular events. Verapixar is a platelet protease-activated receptor abbreviated as PAR1 antagonist, which inhibits thrombin-mediated plateletad. Recently received FDA approval for reducing thrombotic cardiovascular events in patients with PAD. The indication approval was based on a recent study, which enrolled 449 patients with stable atherosclerotic vascular disease who were already receiving dual antiplatelet therapy, of which 14% had PAD. The results showed that treatment with Verapixar reduced the composite primary endpoint of cardiovascular death, MI stroke, although only the incidence of MI was reduced significantly. Importantly, major bleeding was increased significantly in the Verapixar group, thus the true benefit of the addition of Verapixar in these patients is unclear at this time. Ongoing studies with the P2Y12 receptor antagonist ticagrelor and the direct factor Xa inhibitor oral anticoagulants rivaroxaban and edoxaban will further shed light on the risks and benefits of more potent, target-specific agents in patients with PAD. The choice of antiplatelet therapy for P.R.L. in this scenario would be dependent upon what specific cardiovascular event he experienced, as the choice of therapy would be different if P.R.L. suffered a MI versus an ischemic stroke. 3 years have passed, and P.R.L. stopped smoking 6 months ago. His current medications include isosorbide mononitrate 60 mg daily, aspirin 81 mg daily, and ramipril 10 mg daily. Carvedilol 6.25 mg twice a day. NPH insulin 55 units in the morning and 40 units in the evening, and atorvastatin 80 mg daily. His symptoms of intermittent claudication have remained fairly stable until the recent development of a non-healing ulcer on his toe. What options are there for P.R.L. if non-pharmacologic and pharmacologic interventions are not sufficient? Surgical intervention eventually may be necessary for persistent and complicated disease. Because success rates for preventing amputation and post-surgical complications vary from institution to institution, surgery should be considered only for severely ischemic limbs and should be performed in a hospital with a good record of success. Arterial bypass grafting and percutaneous transluminal angioplasty of the femoral or iliac arteries, similar to cardiac revascularization, are 2 procedures that can be performed. Angioplasty is beneficial in patients with localized disease, especially in the iliac or superficial femoral arteries, and should be considered in patients who truly are incapacitated by their activity limitations. Angioplasty with or without stent deployment, atherectomy, and the use of drug-eluting stents in the peripheral arteries are all options. The more invasive reconstructive arterial bypass surgery can be used if diffuse lesions preclude the use of localized angioplasty. The true benefits and pitfalls of these skilled interventions remain unclear. Emergency surgical intervention may be required if acute, persistent ischemia develops. This is frequently due to thrombosis associated with advanced atherosclerosis, although other causes, such as cardiac emboli, cannot be excluded. Both surgical thrombectomy and localized thrombolytic administration with tissue plasminogen activator or urokinase have equal success in alleviating acute limb-threatening ischemia. After surgical intervention, patients are advised to resume and remain on antiplatelet therapy indefinitely to reduce the risk of future events. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 284.